Welcome and thank you for tuning in to Derm Docs, powered by LiveDerm. This is the final installment of a 4-part educational series. This episode, Moving into the Non-Steroidal Topical Therapy Age, features board-certified dermatologists, Dr. Mona Shahriari and Dr. Michael Lewitt.
Hello, my name is Mona Shahriari. I'm an associate clinical professor of dermatology at Yale University, and I am joined by my good friend and colleague, Dr. George Michael Lewitt. Why don't you introduce yourself?
Hello. Well, as alluded to, I am George Michael Lewitt. I'm a partner with the Illinois Dermatology Institute, lead and perform clinical trials with de novo research, and also an associate professor at the Chicago Medical School. And as always, thank you for offering to partner with me.
It's always a pleasure, Mike. Hopefully our audience will get a lot of fabulous pearls today. And today we're going to talk about one of the most exciting shifts happening in atopic dermatitis care, which is the rise of our targeted topical therapies. So let's face it, for decades, our toolkit was dominated by steroids, calcineurin inhibitors. But in the last few years, we've entered an era of mechanism-driven precision topical therapy that lets us really treat earlier, safer, and longer. And AD is a disease where that first step does matter, because most patients, they start and stay with their topicals for a long time, even if we eventually escalate them to systemic therapy. So Mike, why don't you just start us off and tell us a little bit about the first generation of the topicals that we had for AD, our topical steroids and our calcineurin inhibitors, to be exact.
Sure. Yeah. So I think a lot of people don't realize that, steroids have multiple classes. They have allergic classes, but they also have potency classes. So we had anywhere from class 7 over-the-counter hydrocortisone all the way up to class 1 clobetasol. And I think a lot of providers, whether they were outside of, inexperienced dermatology providers, maybe they're a primary care provider or a family doctor, kind of didn't know the different levels of severity. So we were just getting lots of topical corticosteroids thrown in inappropriate places. But in the early 2000s, I feel like I'm about to give a history lesson here. We got our kind of the first of our non-steroidal molecules, topical calcineurin inhibitors, as you mentioned in the monologue there. We had an ointment called tacrolimus, and then a year later, a cream called pacrolimus. Tacrolimus had kind of two strengths, and then which was age 2 to 15 for the lower, and then a little bit higher strength for 16 and older. And again, they were a revelation from the topical corticosteroids, but they had some limitations. I think people forget, because I remember, in early residency having to explain to parents, they actually have a box warning as well for when they were used systemically. And then a lot of times they burned a little bit. So historically they were, a revelation, as I mentioned, because they did reduce the overuse and inappropriate use of topical corticosteroids. But tolerability and overall efficacy, still required sometimes that topical corticosteroid to stagger therapy. I'd have, hey, use your topical corticosteroids on Friday, Saturday, Sunday. Use your topical calcineurin inhibitors Monday through Thursday. And, again, it wasn't until I got probably 2016 when we got our first phosphodiesterase 4 inhibitor, crisaborole, which now approved down to 3 months of age. But that was, again, limited by stinging and burning. So hopefully that was a pretty good historical overview, for the audience. Anything to add?
Well, I think that was a fabulous overview, and you touched on a very important point that I'm going to expand on, the complexity of the regimens that we had with the steroids and non-steroidals historically, because you just said it. You're using your non-steroidal or steroidal Monday through Thursday, and then you're using your other product Friday, Saturday, Sunday, and we give individuals these topicals, send them home. And are we even asking ourselves for a minute what we expect our patients to do? I can't use my moisturizer twice a day if my life depended on it. And I'm sending my patient home with this complex regimen. And without a doubt, they come back 4 weeks later and they put a high potency steroid on their face. And guess what? It worked great. So we're setting our patients up for failure. And I think to your point, when these non-steroidals launched, they were supposed to be the next best thing since sliced bread, but that efficacy piece was lacking. So the steroids were still being incorporated. And I'm glad you touched on crisaborole, because that was our first wave of these more targeted agents, but that burning and stinging, especially in our littlest AD patients, was hard. Like, I see a lot of kids in my practice, and when I hear that, that just makes me cringe.
Yeah, I was in the exact same boat. Yeah, I would give them the what I'd call the eyelid test. I'd give them a sample, say, put this on your eyelid. I'll be back in 5 minutes. If it burns, I won't prescribe it for you. So yeah.
That's a very easy way actually to do it. But now I think things have changed. We're really privileged to be in this targeted non-steroidal age where we have treatments that are more in line with the immunologic understanding of AD as opposed to just that broad suppression of inflammation. And I kind of think these newer agents allow for us to personalized topical care the way biologics personalize systemic care. So now let's get into some of our hot next generation topicals. So the ones that have launched, I would say, over the last 3 to 4 years. Let's start with topical ruxolitinib. It was the first of the bunch and definitely a unique mechanism of action. So do you want to tell us a little bit about it?
Sure. And then if it's okay with you, I'm going to kind of tell you where I place it and also, some of the limitations of the medicine. And obviously we can have good dialogue on that. So topical ruxolitinib is a topical JAK1 and 2 inhibitor. So JAK stands for Janus kinase. It's an inhibitor of that. But what is that pathway? It's kind of like a conduit between signals on the outside and inflammatory mediator production on the inside. So it's currently approved, recently approved, I should say, down to age 2 for mild to moderate atopic dermatitis. It has, BID dosing, and it did keep the same concentration, 1.5%, as we saw previously in 12, and above. So this is, again, correct me if I'm wrong, kind of the first non-steroidal to go head-to-head versus a steroid in a phase 2 dose-ranging trial. So that was kind of cool because a lot of people say, well, is it better than a steroid? Oh, I don't know. I've never tried it against a steroid. We didn't have tacrolimus and pacrolimus versus steroid or crisaborole versus steroid. So kind of neat because they use triamcinolone, which is one of the most frequently prescribed by primary care physicians, family docs, urgent care, emergent care, and even some dermatology providers. And it actually outperformed the triamcinolone, on both mean percentage from baseline EASI scores, but also on the itch scores. So I thought that was really neat. Does that, play any patronage to your prescribing habits when you see that?
Well, absolutely, because I think sometimes we tend to overestimate the efficacy of a steroid. And that particular trial actually showed us our trusted handy-dandy steroids actually may not be as good as we think they are. And the safety that topical ruxolitinib brought, the ability to use it for longer periods of time as opposed to the short 4 weeks. I think in the trial, you mentioned they cut it off after 4 weeks because that was the limitation for the steroid, not actually topical rux. So this has definitely been a game changer in terms of my prescribing habits.
Yeah, and a few other points that I love about that drug that were interesting is they did another phase 2 trial called Scratch AD where they actually showed about 50 patients with mild to moderate atopic derm that actually saw a mean change in their itch scores as early as 15 minutes, and I thought that was a joke. And I know this is not atopic dermatitis, but we had a brutal summer in Chicago, and I live on the river, Chicago River, so it was mosquito central. I actually took a little topical Rux and put it on a mosquito bite where I was just tearing my ankle to pieces and couldn't sleep, and it actually did get better in 15 minutes. So I thought, it's funny. Nobody really thinks about 15 minutes versus an hour versus a day versus 2 days, but for somebody that's itching, it is important. But unfortunately, the one thing about the drug is that the label does read that you have to avoid the use of it in combination with therapeutic biologics, other JAK inhibitors, or potent immunosuppressants. So, I don't know about you, but I have had issues in the real world. If I don't write it first before a systemic agent, sometimes it, will kick the patient out of the systemic therapy. And I do feel bad because that's just the way the label read for the systemic version. But I don't know if you've experienced that at all.
Yeah, so I absolutely have. And it's funny because a couple of colleagues, we published something in an abstract form manuscript coming out back in June of this year, where we actually challenged that concept. We looked at real world cases of patients on systemics, whether biologic or oral JAK, who had combined it with topical ruxolitinib, and they didn't see any change from a safety standpoint. In fact, we actually saw efficacy benefits. So I really do think this was an unfortunate event. This language is on the label. And even though in the real world, it can impact access to the drug. I have to do peer-to-peers and talk to insurance companies and maybe even finagle my note a little bit to say I stopped one thing and now I'm starting the other thing to get the approval. I don't think that it holds any merit. And I think in the real world, we need to remember that we make decisions based on science, not necessarily based on some fear that the FDA had to put something in the label. Again, this is me talking, but sometimes I feel like the FDA labels a suggestion and then we figure out what to do with it in the real world.
Yes, and thank you to you and your colleagues for doing that manuscript because it, I think that's going to really help a lot of patients able to apply that data, to a human.
Exactly. So I think that was a fantastic review, and the speed that you highlight with topical Rux and specifically with the itch, I think that was very important, and that's something that I've really encountered in day-to-day clinical practice. But another drawback besides the combination with systemics is that it's twice daily dosing. So I know sometimes for some patients that can be tough, but we do have 2 other topicals in our space, topical roflumilast, tapinarof, both of which are once daily. approved for atopic dermatitis, now down to 2 years of age for both of them. Roflumilast just got the approval not that long ago. But do you want to chat a little bit about, let's start with roflumilast and then we'll go to tapinarof.
Yeah, that sounds good to me. So roflumilast is actually our second to market phosphodiesterase 4 inhibitor. Why does it work? Well, really interesting. I'm going to kind of nerd out and go into the petri dish again. It actually has a much more potent binding affinity for phosphodiesterase 4 than its predecessors, even its oral predecessors, and therefore really kind of prevents that decreased conversion of cyclic AMP to 5-AMP. So in a nutshell, what's that doing? Well, it is reducing those pro-inflammatory cytokines, but increasing the anti-inflammatory cytokines. So kind of tipping that seesaw toward the direction we want to go for a chronic, debilitating inflammatory condition like atopic dermatitis. The 0.015% cream is now FDA approved down to 2 for mild to moderate AD. And as you mentioned, for once daily use, which again, I'm in the same boat. Nobody needs to hear my medical problems, but I can barely take my GERD medicine twice a day. And I'm like, I need something that's once a day. Give me something delayed release because I keep forgetting the second one. So that once daily dosing is, pretty cool. And some interesting, traits about the drug that I really like. Let's start with its vehicle. I think people don't understand how important a vehicle is. It's not, it'd be like, would you rather drive a Maserati or a 74 Yugo? Everybody wants to drive the Maserati, right? That's a good vehicle. So the vehicle, a little bit different in terms of, roflumilast, it's moisturizing, does not have any known sensitizers or irritants. And it's, of the three we're going to discuss, it's the only one that's devoid of propylene glycol. Like the other two drugs, can be used for any body part as long as it's necessary. And has really great and significant improvement in, in global assessment, EASI-75, and itch reduction, despite only a 4-week study to kind of reach that primary endpoint. So, especially for using, you really just kind of the very, very low adverse event profile with very little systemic absorption. And I think the best thing that we can talk about, I'm jumping ahead of myself, with roflumilast and tapinarof is neither drug has any labeled warnings or precautions and has no drug-to-drug interaction. So I can kind of use it. If I need to use a systemic agent to repaint the wall, I can use roflumilast as my touch-up paint. Again, that once daily, in my opinion, just improves compliance. So I think that's again, I probably am long-winded. I'll be guilty of that a few times today, but any other points that I missed?
No, I think that was a fantastic review. And a couple of things that I'll add is we talked about crisaborole. That's how we kind of started this next generation conversation. And that too is a PDE4 inhibitor. And I kind of think people automatically, when roflumilast launched, they assume this is just another PDE4. But I think you and I can agree, this is not your grandfather's PDE4. We're talking about a completely different level of next generation inhibition. And that's really giving us the much better tolerability profile, but also better efficacy overall, durability of response. So obviously we can't always link a mechanism of action to efficacy and safety, but I think we all see something special with this drug that wasn't present in the medications of the past. The other unique thing is, I don't know if you remember that study where they looked at the leading moisturizer and compared its hydration to roflumilast, and it was quite comparable. And that's one thing I've personally noticed. So if I need a little bit of moisturizer, I know if I grab my tube of roflumilast, that can actually give me some hydration in addition to the anti-inflammatory benefits that it has. And especially for atopic dermatitis population, I think having hydration mixed into any treatment, the cosmetically elegant nature of any topical that we use is going to go a long way in terms of not just compliance, but also enhancing the efficacy of the therapy.
Yeah, and I'll add to that the fact that they're, again, devoid of any kind of sensitizers or irritants, as I mentioned. People with AD, not everybody with allergic contact derm or irritant contact derm or atopic dermatitis, sometimes they have a mixture of the other, you can have allergic and atopic at the same time. So what you don't want is when someone's already got that skin that's ready to be sensitized, throwing things that could cause an allergic contact derm on top of the atopic derm. So knowing that it's, so hypoallergenic, and I know that term gets thrown around. Every toothpaste says dentist recommended, right? So every cream is dermatologist recommended, but it's not that way. So I think it really is nice to know that you're not going to fix one problem and create another.
Oh, absolutely. And then we'll go through full safety afterwards. But I just want to touch on tapinarof because I know that's also a little bit different because I like to call it the natural agent based on how it was derived. And some of my patients that are into kind of the organic therapies, they tend to like the story behind where tapinarof came from. But it's different than our other agents, which are inhibitors. It's actually an agonist, the aryl hydrocarbon receptor agonist. And I think that actually gives it some different kinds of power in terms of the novelness of the mechanism. It really helps tone down that Th2 pathway in a different way than we're normally used to doing, because we're used to shutting things off in a pathway, not enhancing our own body's ability to do certain things. And then we end up with better barrier repair, and increase in different proteins that are important for the integrity of the skin. So overall, I think the mechanism of topical tapinarof is very interesting. But again, we see that efficacy in the short term and the long term. We see that speed of response early on, and that once daily regimen. Oh my gosh, I could not emphasize that more. That makes a huge difference if you're a patient. And I think one thing we didn't touch upon is these newer agents, they can safely be used anywhere head to toe. And that is fantastic because we both know we're going to have patients who come in and see us in a snapshot of time. Let's say you have AD on your arm or your leg, but you go home, now you develop it on your face. You're probably going to use the cream that I gave you, but now I have peace of mind that if you use it, it's not going to be the end of the world.
Not only the end of the world, but it's also going to work. We've got that efficacy and the safety. And, again, the other thing about tapinarof is it's terribly bioavailable. So that is great, which means there's like no systemic absorption. So when I sit down with a parent, I'm like, yeah, you could, please don't, but you could swallow the tube and you couldn't find it in the bloodstream if you tried. The metric they used, when studying that drug, it was, very, very difficult to find. So to me, especially for kids, that's really, really an important safety tip. It just eases that conversation in the room. And again, in downtown Chicago, as you mentioned, it's organic and gluten-free.
Yes. Now, with respect to all three of the medicines that we touched upon, are there any safety signals that you tend to educate your patients about? I'm talking ruxolitinib, roflumilast, or tapinarof, anything that is a key part of your patient conversation?
Sure. So obviously with Rux, I do mention the box warning because I just don't want a phone call later. Do I harp on it? Absolutely not. I just tell them it's there. I tell them the history behind the JAK-STAT pathway, in rheumatoid arthritis and our oral surveillance trial. We won't get into that. But the one thing I do, if some folks especially have pronounced facial atopic dermatitis, I will mention that there's a small proportion of patients on ruxolitinib that can develop acne over time. It's usually temporary, but every once in a while it can occur. Responds to standard therapy, but in an atopic dermatitis patient, some standard therapy that we're used to using, we can't use as often because it can make the atopic dermatitis worse, such as retinoids, such as benzoyl peroxide containing products. That's kind of the one thing. Anything on Rux that you would add?
No, those are the key things. It's funny because I feel like on the face, sometimes I actually use it to treat periorificial dermatitis, which is not AD, obviously. We use it off label, but it somehow helps in that. And that's more of like this papular pustular eruption. So I feel like we still don't know the value of this JAK inhibition that it brings.
I agree. And roflumilast, the one thing I will mention, it is a phosphodiesterase 4 inhibitor. So it's very tolerable medicine. But if you've got a patient with a very large body surface area, they did have some very minor, I'm talking like fewer than 3% systemic effects. So we know from a drug that we give like a Premolast of headache, nausea, vomiting, diarrhea. Again, these are minimal and they are commensurate with with BSA. And then, again, I don't get phone calls with this. It is really rare. It's just things that we saw in their trials just being compliant. And then tapinarof, the one thing's a couple, recommendations to that drug that I've always made. We saw more in the psoriasis arm. I know we're talking about AD today. Because it upregulates stratum corneum components, there can be an element of almost like keratosis pilaris, like folliculitis. So some tips and tricks that I'll tell my patient: apply it at night, and especially if you're using it in an occluded area. Don't do it, put it on and then go for a 30-mile bike ride. That can exacerbate, especially if you're putting it in intertriginous areas. But those are kind of some of the adverse events. And I like to tell folks to try to color within the lines with that drug as well.
I like that, color within the lines. But no, I think to the point earlier, what we just went through was a very brief safety review for all three topicals, which goes to show there isn't a lot for us to be worried about in contrast to the long list of things with steroids. And then with calcineurin inhibitors, they were actually probably on the safer side. Tolerability was more of the issue, but I think that's another virtue of this generation. But now that we have these novel next generation topicals in our toolbox with FDA approvals down to 2 years of age across the the board. How are you integrating it into clinical practice? And is the approach different, whether you're treating adolescents and adults in comparison to the youngest kiddos?
Sure. So I'll kind of go down the line. How am I approaching patients? Well, I don't think it's wrong for any atopic dermatitis patient to have atopical. Now, I'll use it kind of three different ways. One, hey, let's try this. We'll use it as monotherapy. Excellent. Or, hey, I think we're going to probably need a biologic, but or a systemic therapy, but I may need some labs. Why don't you start on this before we get you approved? Or, hey, you're doing great on your systemic agent, but you flare in the summertime. We really don't want to switch you to another systemic agent because you're doing pretty darn well the other 9 months of the year. Why don't we add this topical on again, as I mentioned, as your touch-up paint? So, the nice thing is, as you mentioned, so I'll steal your thunder, I'm not worried if somebody goes home and puts, tapinarof or roflumilast or ruxolitinib on their eyelid. I am going to be a little bit, sensitive if somebody goes home and puts clobetasol on their eyelid, right?
Absolutely.
So, 100%. So, it is nice to know, and I think the safety reassurance I give to my adults are, hey, I can give this to a 2-year-old, you're just fine. But it's a one-stop shop, improves compliance, and then do a little bit with me because it's fun. I don't have kids, but how long does it take to put a kid to bed?
Well, tonight took about 30 minutes. And she's a good kid. It could easily take over an hour.
Okay, so I can't imagine having a young kid with atopic derm, and you're like, all right, well, we're going to put, our triamcinolone on your AC fossa, papilia fossa, some tacrolimus on your eyelids. Oh, mommy, it burns. Take it off. Then you have to wipe that off. Then you have to read another story, and then apply some more CeraVe, then put the cortisone back on. I can't imagine, having a kid, the bedtime routine, not just on the kid, but I think about the parents, how difficult that must be if you can just be like, all right, one cream on all areas, one story, go to bed. So to me, when I talk to parents, I consider their time, not just, the kids' time. It's obviously the kids' safety and efficacy. But so those are kind of things that I think about, having a little fun with the topic.
Yeah, I think everything you said resonates. And for someone who doesn't have kids, you pretty much know the routine very, very well. My daughter, actually, she had a little bit of AD when she was first born. And we're talking not that bad. CeraVe, a little hydrocortisone, nothing crazy. And even that was a lot, given everything else that you have to juggle when you have a child. So to your point, that family impact cannot be discounted. The other place I actually like to integrate it with that we didn't really touch upon is you have those in-between ages where, like, maybe after 6, but before you get to 12, you're really wanting to be independent, but you're not really as independent as you should be. And many times children at that age, they want to be the one using their topical. They don't want mom's help. They don't want dad's help. What I love about this new, these next generation topicals is that if I have a child who wants to be independent and we give it to them, let's say they screw up the regimen. They put the wrong thing in the wrong place. They put too much of it maybe. They're not going to do harm. I do get worried when a 7-year-old is trying to put this complex regimen of steroids and calcineurin inhibitors on, and they put the wrong thing potentially on a sensitive area, and now we're dealing with side effects.
Yeah, I know you're promoting autonomy in that kid right away. And again, the safety is it's great. But again, it's how important is safety if it's not working? So it's nice to know that you really have 3 great options, to cover both safety and efficacy.
Exactly. And I know with these topicals coming to the landscape, there could be other challenges because they sound fantastic. I'm sure everybody that's listening right now is like, well, why aren't these jumping off the shelves like Ozempic? But access can sometimes be a challenge. They're novel, they're not cheap. So do you have any tips and tricks from the standpoint of getting access to these medications?
I do. I don't like to be a negative guy, and I hate the word, tried and failed, but putting your tried and faileds to the notes to the pharmacist, especially if you have an electronic medical record, is really, really helpful. So you can see that, and getting a good history, having your medical assistants and yourself getting a really profound history from the parents, from the patients about what they've tried and failed. And if you said they've tried and failed topical calcineurin inhibitors, and or topical corticosteroids, a lot of that gets you past kind of the first step. I know that's going to be state to state, depending on which medicine you're using, and it's going to be specific to each medicine. But that being said, that can be really, really helpful. The devil's in the documentation. Other things, please put an itch score in. It's easy. You can ask your medical assistants. It's a 11-point scale, 0 to 10. Worst itch you felt in the last 24 hours. And then the body surface area and the global assessment. We know these drugs, tapinarof approved for mild, moderate, severe, the other 2 for mild and moderate. Make sure you're documenting accordingly so you're not having any, managed care companies saying, oh, no, that's not appropriate. So again, BSA, itch score, global assessment. These are really important things that can take somebody, or a scribe, if you're using a scribe in the office, a matter of seconds to elicit from the patient in the exam.
Those are fantastic tips. And I'm just going to take it all the way back to the beginning. Make sure the diagnosis is correct. Because again, as derms, we sometimes go off label. We might say things are AD, but have a different fancy terminology for them. So definitely make sure you're using the diagnosis code atopic dermatitis. And I love that approach of setting your note up with the BSA, IGA, itch score. Because if you think about it, many of our patients may go on to a systemic at some point. They might want to stay in topical realm, or over time, their AD might evolve, or this might be a bridge to a systemic agent. So why not just set your note up for a systemic from the get-go? I feel like it's just so much easier than now playing catch up and trying to get approvals down the road. And also specialty pharmacies. Many of these novel topicals, there are contracts with various specialties. I'm not going to go into the different ones because I feel like depending on the region of the country you're in, there'll be a different one that your representative is going to recommend you use. But talk to your reps, talk to your field access specialists, because they can help guide you on ways to get these medicines easily. And if you write the drug, would you say the majority of the time you can get any of these three drugs?
For my commercially insured patients, absolutely, and luckily, and very luckily, for both me and for my patients in this area, they have good coverage, and that's been very, very helpful. And like you said, partnering up with one of the specialty pharmacies, they do a lot of the dirty work for you. And there's even some newer AI programs, like I won't use names, but ones that are affiliated with different EMRs that have been helpful as well.
Yeah, I completely agree. We got to use AI to our advantage. But I think we went through a lot of fantastic information on not just the past, but kind of where we're at in the present and where we're headed in the future. Speaking of the future, do you think there's a paradigm shift on the horizon? Are we ever going to let go of our tried and true topical steroids?
I think there is, and I think that there has to be. So again, as new residents come out, they're getting exposure. Young providers are getting, dermatology providers getting exposed to these new medicines. The more we use them, the more the insurance companies will say, yes, we can, put those on formulary. And it's important. Now, there is an appropriate and an inappropriate place for a topical corticosteroid. But if I can safely avoid them, but still get a quick onset of itch reduction, barrier repair, while reducing the risk of stria, systemic absorption, or any of the other acute or chronic potential adverse events of a steroid, and we can get them for our patients, these three medicines should be changing the direction of our prescription habits and our compliance and patient care.
I completely agree, because I know even in my clinical practice, I tend to reach for these over my topical steroids for all the reasons that you mentioned. And I think what we're not trying to say that topical steroids are bad, that you should never ever use them again. But I think it just comes back to that concept of steroid stewardship, where you want to use them appropriately and not overuse them. And I always think of my steroids as a bridge to somewhere, not a bridge to nowhere. So we have to have a game plan on what to do when you can't use the products anymore. And these are a really nice one-stop shop as a monotherapy for your patient, as a combination with the systemic, or even if somebody needs things to be cooled down a little bit more quickly, give them 2 weeks of a steroid and then transition to this for the long term. So I think there's a lot of ways that this paradigm is going to start to shift. And hopefully in our generation, we'll get to see it, because I know both of us trained at a time where we didn't have a lot of topicals, period, let alone targeted topical agents.
Yeah, I couldn't agree more. And I think that bridge to somewhere versus nowhere, if that's not patented or a book, it should be. So you better patent that as soon as you can. And then again, yes, if I do use steroids, I give a very responsible quantity. It's not a big old jar. It's not, 60 grams with 12 refills. But if my one turns to an 11 in terms of refills of one of our non-steroidals, I just don't have that fear of abuse. So it really, that paradigm shift, as you quoted, is a trend that should occur if it's not already.
I couldn't agree more. Now we are at the end of our time. So do you have any final words of wisdom for our audience?
No, I think the best wisdom I could have given is, how some of those tips and tricks to get these medicines. And the only thing I can say is, if you haven't tried them, try them. You're doing your patients a disservice, for not using these targeted therapies, because AD is just, as I mentioned, chronic and debilitating, uncomfortable, affects sleep, work productivity, growth patterns. We've got medicines here that should be a part of our algorithm, to treat and then further to control these folks.
Yeah, and just to piggyback off of that, I kind of feel like for the longest time, topicals were a step before we got to like, the real medicine. And that's no longer true because we're really in an era where our topicals are targeted medicines and they're delivered through the skin instead of a syringe. But I think it's fundamentally changing how we treat AD from that very first visit. So if you're a patient with atopic dermatitis, it is a good time to have AD because thankfully the toolbox is ever expanding and there's a lot of options on the horizon. Well, thank you so much, Mike. I know anytime you and I chat, not only do I have a wonderful time, but I learn quite a bit too.
Well, the feeling is completely mutual, and always being included with you is is a privilege in itself.
Stay tuned to Derm Docs, powered by LiveDerm, for more dermatology education coming to you soon.